Are there questions? Yes, please. Please stand up, go to the microphone, or receive a microphone.
Dieter Scholer. Patrick Hunzig, at the beginning in your very nice overview, you did spell out the number of criteria for nanoparticles which have to be fulfilled. And so my question is, where are we today in the selection of molecules and of a design of nanoparticles to go into clinical studies? And did you already have some feedback from regulatory agencies in this respect? Thanks.
Yes, there are worldwide several groups which have in their hand by now potential materials that are suited for such tasks. So you have seen that Athero Nano Consortium has several materials in testing. We have several materials in testing that fulfill the criteria which I have outlined. So in general, I would say that the research is at the late preclinical level in several groups, and we are upcoming to figure out how these translate into clinical trials. Now, for clinical trials, we need the GMP materials and we need to have the regulatory okay, and this is hard work. But at the same time, as we have seen with the regulatory bodies yesterday, they have really opened the pathways, the doors to also advance academic research and early SMA work of startups and SMEs to this pipeline of preclinical, clinical trial phase. So I think the door is much more open than maybe 3 years ago, and I'm very optimistic that we are really moving forward. Yes, please.
Get the microphone.
Yes.
The microphone.
No, that's fine.
So, yes, so I wanted to bring the discussion to the issue of the inflammation. So Patrick started saying it's a dangerous thing to target the inflammation because it can have undesired consequences. Then I have seen also in the other speakers that is a very important part. Could it be that it's because what we are doing is to treat the inflammation in a kind of indiscriminate manner and not looking to the quality, so to the type of response that should be really a target? This is one question. And the second, what is known about the changes in the metabolism, and particularly of the macrophages in the plaques?
So my answer is absolutely true, and I leave the details to the other people of the.
Okay. As I tried to show in my presentation, the interaction of the macrophages is so complex, and so we thought usually that the M1 type is the aggressive subtype, and the M2 are the more protective ones. But it, as I showed you, the OX-LDL influences also the M2 subtypes, and so to come with a simple drug to this process and to switch it down is also a very dangerous thing, because it does not fulfill the criteria of the fine-tuning and doesn't reflect the fine-tuning. And so we have to think about to influence the inflammation at the right time in the right way. Acute inflammation at which time? We don't know. And so a combination of drugs with a more broad spectrum, which stabilize the process and allows the chronic inflammation to do the healing process, may be the right thing for this complex.
I just want to add also that most of the studies were done in mouse, and the plaque in mouse as compared to plaque in human could be really quite different. And of course, the treatment have to take into consideration. It's why the work, for instance, Eric, are very important to see in human patient what type of macrophages, the activity and so on are important.
So basically, I'm very pessimistic about extrapolating individualized inflammatory activities to this complex process in humans. So even the acute double balloon rabbit model is completely irrelevant if you compare it to the behavior of atherosclerosis in humans. It only teaches you a little bit about inhibiting the acute inflammation. But what I would predict is wait one more year and then ask your question again. Because within 1 year, we will have the CANTOS study, where IL-1 beta inhibition, there's a lot of data on that. If that trial is positive, brilliant, then we can actually start making steps. And if the CERT trial, which is a little bit delayed and will be 2 years, 3 years maybe, but MTX, which is very non-specific, actually if that trial is positive, then we are in business. And what do those trials do? They take away the overshoot of inflammation and try to avoid the immune suppression. And I think basically that's the only way we can do. And if that doesn't work, I'm very skeptical about individualized choices of one particular subset of cells.
Paolo De Cuzzi, Italian Institute of Technology. Thank you for the talks. Couple of questions. First of all, I really love the fact that you are labeling the nanoparticles with radioisotopes, SPECT, PET, whatever. Do we have a sense of how many particles they actually get into those vascular lesions? In cancer, we have an idea, and we are starting learning that there are very few particles that are actually getting into the cancerous lesions. I guess many scientists are very happy to cure cancer. Many scientists are very happy to somehow induce regression of plaques. Many cases also limit progression. But my feeling is that maybe we don't have a clear sense of how many particles are getting there, how much drugs we're actually getting into the lesions. And this is the first portion of a very long question.
Okay.
And then the other is more a curiosity. Was more a comment. The other is more a curiosity. Do we have an idea of the rate of trafficking of monocytes in and out of these plaques? Because if we want to use these monocytes as Trojan horses, we probably need also to understand if we get one monocyte every month, one monocyte every day or hours or minute. Thank you.
Okay, so I will try to answer the first one. I will leave the second one to other people in the table. It's really a right question because we don't know enough about plaque permeability, especially in human, as we said just before. Mouse model, even rabbit model with double injury, fat, cholesterol, and so on, feeding. It's not at all relevant for human plaque. So we have really to design the nanosystems that can enter the plaque, first for diagnosis, and later on for treatment. It's why we don't know which type of particle, what could be the nature of the particle, what could be the size, and the size will be very important. And in our consortium, we didn't discriminate from the beginning what could be the right particle. We designed all of them, different chemistry, different coating, and different sizes. And then we evaluate them. And the most promising one should go to clinical trial, and it's what we need. And of course, radiolabel methods are very important because you can try to quantify, to localize this nanoparticle, the loading, the drug. If you have a drug, either the coating, you can have double labeling. So quantification, biodistribution is also important. So one of the key issues, and I couldn't tell you more, but we have one promising compound. It's what we are working on. With a specific design, specific size, and we want first to address plaque permeability in human patients. We have promising data in animals, so we are doing now, starting the GMP production of this nanosystem to to start the patient, and with the help of Eric, for instance, we are aiming to go to imaging of plaque with this type of nanosystem. We don't know enough. I completely agree. So we have to try and to test this nanoparticle, and we are far away of all the studies that have been done in cancer. So we have to learn and to see what is the permeability of plaque in human, what we know, what we don't know, and to make progress in this type. I have nothing about cell treatment and so on, but if you want to comment to the second part.
I'm not sure whether we are actually going to use the cells to deliver the compound, because basically it's quite a job to handle cells without activation. You can handle cells without activation. You can label the cells and reinfuse. We didn't see a lot of activation, but as soon as you start to load cells and then reinfuse, that might be a problem. But your question was, what about the speed of the entrance? Well, I showed you the slide, which is in JACC publication 214, that within 2 hours, 4 hours, and 6.5 hours, there is a significant signal of labeled white blood cells in the advanced atherosclerotic plaque. So that implies that trafficking is also in human plaques, well, quite fast actually. We can't quantify, but we know that if you want to trace it, there actually have to be quite a number of cells. And that actually coincides with the data by Robbins and Narendorf in Boston, where they actually showed that the half-life of the cells in plaques is not so long. Maybe in experimental models it was 19 hours, etc. So that implies you continuously need new influx of cells, which completely is coherent with our findings of the increased bone marrow activity, because actually that shows that if you need these cells, you actually have an active influx and an active new production of these cells. So I would suspect that also in humans the turnover is quite rapid.
These are spike processes or continuous for the life of the patient? Sorry if I this is a very important.
Yeah.
It's not spiked, because basically we evaluated horrible patients with advanced disease, but we evaluated non-acute patients who were stably treated and not facing any planned interventions. We didn't stress them, fasting conditions. So these were optimal conditions, which implies it's a continuous process, and this is by no means post-myocardial infarction or etc., etc.
You have the microphone very close to you.
I would like just to add. No,
Yeah.
it's good. Yeah. It's even more complex, Paolo, because even in the same patient and in the same artery, you have different maturity stages of plaques. So this is very complicated. It's much more complicated than cancer, finally.
Thank you so much for your talk. So this is not really my field, but I was wondering, there's a lot of talk about macrophages. What do you think is the role of neutrophils, since they're the most abundant white cells in the blood? So I'm sure they have some kind of interactions with plaques.
This is a very good point. What's the role of the neutrophils? We don't know in detail. It is an inflammatory process, and so neutrophils will also play a role. But may I give you one additional point? I mentioned the process of the efferocytosis in the plaque. If the apoptosis is growing too fast, and if there is this balance between necrosis and immune-mediated inflammation in the plaque lesion, all these components, also maybe neutrophils, cells of the inflammatory process, may play together in direction of exacerbation and destabilization of the process. And it is our challenge, our therapeutic art, to find out at the right moment the drug which stabilizes the process, as the process is so complex and changing over time, it must be a drug with a certain safety range, which switches down a little bit, but not too much, and restores the physiologic action of the inflammatory process, the repairing facet of the inflammatory process. And this, I also tried to show this, that lipid oxidation is seen bad, but some cases the grade of lipid oxidation influences also the fine-tuning of the macrophage immune system interplay. And we have to consider so many facets for a good drug.
So it may not be your field, but you asked the tricky questions. Congratulations. So basically, if you look at recent data by, Peter Libby is as godfather of vascular biology. Whenever he starts mentioning cells, you should be aware. So recently, Peter Libby re-emphasized the importance potentially of neutrophils with nets formation, where they give these extracellular trapping systems, and they actually stimulate it. It was brilliant data in preclinical models, no data in humans. So brilliant question. Look, for instance, acute coronary syndrome, myeloperoxide is the only good predictive factor for the risk post-ACS. So what is the most single abundant cell producing myeloperoxide? Neutrophils. So there is data, but basically clinical data, we don't know yet.
Another outsider. So my question is, for what I understand of human physiology and lipid physiology, is that lymphatics are pretty key in the metabolism uptake of lipids. So what is the role of lymphatics in atherosclerotic plaque formation?
Draining lymph nodes and spleen play a role for the critical amplification of the disease. And also I think the gastrointestinal immune system is very important. I showed one slide with the trimethylamine N oxide, which their lifestyle comes into play. The L-carnitine from the meat, if it interacts with the intestinal microbiome, trimethylamine can be produced if the intestinal microbiome is still disbalanced in a special way. And meat diet rich in meat with L-carnitine and other aspects can favor this switching of the microbiome, that certain bacteria strains produce this DMA, and this DMA may be an additional important puzzle to understand the atherosclerosis in people which have non-increased classical Framingham risk factors.
What I mean, though, is not in the uptake phase. I mean lymphatics that are in the adventitia of the arteries, so the local lymphatics, which is also deeply linked with macrophages. They don't move necessarily through blood vessels, they move probably through lymphatics.
They could play a role for a successful transport of a drug into the plaque. If we compare it with the situation in cancer, the decreased lymphatic drainage of the tumor favors the accumulation of nanoparticles in the tumor. This can be also true to some extent for the atherosclerotic process, but I don't know the details about this role of the lymphatics, but they may also play an important role, yes, it's possible.
Lymphatics is really a question mark. Nobody has studied so much. As you said, it's in adventitia. But where plaque happens, it's subendothelial. So it's a barrier in between smooth muscle cells that do not have lymphatics. Yes, exactly. It's in the outer part of the artery. So, but nobody has studied that systematically, as Professor Mangia said. Yeah. Could play a role.
Very interesting. The hypothesis of the hematopoietic stem cells are in the, let's say, in the beginning of, or potentially in the beginning of the process. Is any idea about how occurs this priming process of the hematopoietic stem cells in terms of inducing this metabolic rate and then afterwards inducing the progenies to get this kind of phenotype?
Wow. Again, a beautiful question. Let me pose the following to you. If you have the risk factor elevated Lp(a), we know it's a massive risk factor of atherosclerosis. Now, suppose you have an Lp(a) transgenic mouse. You take the bone marrow and you put the bone marrow into a wild type, other kind of mouse. And then you evaluate what cells in his ordinary white blood cell fraction will actually be most abundant. You can do that by doing bone marrow transplant with chimerism, etc., etc. It's the cells from the Lp(a) transgenic mouse. But high Lp(a) is not present. So that actually teaches you that something happens at the level of the... Same holds true for diabetes. It was... Dada, who used to work with Matthias Nahrendorf and now moved to another lab. So it implies that something happens at the level of the bone marrow programming, which you can, even if you take away the initial stimulus, you can find in the second mouse model. Now, if you and I would sit down with a cup of coffee, cappuccino, and we would say, what causes reprogramming in bone marrow cells, which is independent of the original stimulus, what would you answer? Epigenetics. So there's only one factor which stays for weeks to even months without changing the genes, obviously, because the genes are the genes, and in absence of the risk factor. So there's a whole new interest in epigenetic remodeling by risk factors of, among others, the bone marrow cells, but also the circulating white blood cells. That's till date speculation. But I think it's a beautiful speculation, and we should provide the answer.
One short point to this question, which could be possible also. If there is a systemic endothelial perturbation by oxidized LDL or by certain LDL subtypes, the small and very dense LDL subtypes make harm and perturbation of the endothelial cells, the stimulus for the bone marrow will increase to produce maybe inflammatory cells, macrophages, which adhere to these harmed endothelial cells, and so the process is going on. And so I think LDL subtypes and oxidation of LDL and the grade and this fine interplay with the perturbation of the endothelial cells in the vessels, in the system is an important switch or something like that. Maybe.
Now it's time for a last question before we move to the...
Sure. It's another outsider, so you may differ.
Oh, are there any insiders?
So I like very much the comment that you make about epigenetics. Now, epigenetics is driven by the environment. What I believe is that in the plaques, there are two major factors that they are driving maybe the change. One is the necrosis, and the other is the hypoxia. And in both cases, these are mechanisms that change the metabolism of the cells, making a kind of glycosis in aerobic conditions, in the case of having maybe a high diet, that can occur in diabetes, or when you have actually not oxygen, so you have to stop the Krebs cycle, And one of the things that the cells do is to stop at the level of the succinate dehydrogenase. So you increase succinate. Succinate can activate IF1 alpha and can enhance IL-1, but it's even released by the cells. And there are many cells, like the macrophages, that they have specific receptors, GPR91, that sense as a danger signal and propagate this kind of response. So you could imagine that this can end up even into a full machinery, into the epigenetic, or even on the activation of these macrophages, that independently if they are M1 or M2, they could have a kind of aggressive phenotype. And so, I don't know. I wanted to see if you have any comments to this.
It's Mihai Netea is a very respected friend, and he initiated the whole epigenetic field in innate immunity, and he just published 2 science papers a couple of months ago where he, exactly as you now imply, he shows the inherent link between intracellular metabolic switches from lipolysis to glycolysis or promoting glycolysis in endothelial cells and their relation to reaction patterns as opposed to the epigenetic control. So then I'm a clinician, so then I start gazing, but it's beautiful papers and science accepted them, so they must be true. So I fully agree with you. There is an inherent unexplored, relatively unexplored link between changes in metabolism within inflammatory and endothelial cell types, epigenetic control, and activation patterns. So I think it's completely correct.
And at the same time, we can say that functional nanomaterials are very promising sensors to elucidate these questions much more in the future. Because you don't only deliver a drug, you can also deliver a reactive system which really signals you what's going in situ in these blocks. So I also believe that these efforts in nano-athero will not only contribute to treating atherosclerosis, but also to understanding atherosclerosis much better. Okay, so thank you for your presence, your interesting, stimulating questions.